Hello, I am Dr. Keith Burke, a behavioral sciences professor in the Alcohol and Other Drug Studies program at San Diego City College. The AODS program is a vocational training program for students who desire to become certified alcohol and drug counselors in the state of California. It is also a fully accredited college-level coursework program, meaning that students who take the classes to meet the requirements to sit for the state certification exam as an alcohol and drug counselor are also gaining college credits towards associate's degrees and ultimately bachelor's degrees and whatever their academic goals may be. Today, I am going to talk about some very basic foundational motivational interviewing and solution-focused counseling skills. In the AODS program, there are 4 clinical skills courses: Introduction to Counseling, Family Dynamics in Alcohol and Drug Counseling, Co-occurring Disorders in Alcohol and Drug Counseling, and Group Dynamics in Alcohol and Drug Counseling. Our family counseling class is one of our level 1 courses, so it's a foundational course and sets the stage for some of the skills that are needed in some of our more advanced clinical courses, such as the co-occurring disorders and the group dynamics course. In all of our clinical courses, students in the AODS program get a lot of hands-on active learning. We teach concepts, and then students are given the opportunity to practice those concepts in scenario-based types learning that mimic what they'll end up doing out there in the field working as alcohol and drug counselors. In the Family Dynamics course, this lecture is taught very early in the semester to set the stage for the scenarios that students will be doing throughout the semester. As I said, in all of the courses, there is a lot of scenario-based learning, and in the Family Dynamics course, students practice every single week on various scenarios related to treating clients and their families in substance use treatment facilities. In order to do this, students are taught a variety of clinical counseling techniques. Motivational interviewing and solution-focused counseling are 2 of the foundational evidence-based practices for working with people who are in substance use treatment facilities. Students get a lot of motivational interviewing and solution-focused counseling training throughout the course of the AODS program, but in order to do some of these scenarios early on in their training, students need to learn at least the basic foundational techniques. So today, I'm going to cover some of those basic techniques that students utilize in motivational interviewing and solution-focused counseling, with the expectation that as students move through the program, they will get more and more practice and training in each. Motivational interviewing and solution-focused counseling are similar in some ways and complementary in many other ways. And as I mentioned previously, they really form the foundation of doing clinical work in clinical treatment programs. Most students, when they first start the Alcohol and Other Drug Studies program, have the desire to be helpful, but don't have any clinical training. And typically people without clinical training, when they're trying to counsel people, think that the best way to counsel people is to talk all about your own experience and give lots and lots of advice. Neither one of these are actually very helpful in terms of motivating people and assisting them with the things that they have going on in their own substance use treatment and in their own lives. And so motivational interviewing and solution-focused counseling turn those into actual techniques that have been proven to work. Evidence-based practices is a phrase used in the clinical field for approaches in which there is research to establish the efficacy or the effectiveness of these techniques. We'll start with motivational interviewing. Motivational interviewing really turned the substance use treatment orientation over on its head. And it was the first of the clinical skills practices that was specifically developed to treat substance use disorders. Prior to that, as substance use treatment moved into the medical field and the behavioral health fields, clinicians typically used techniques that were borrowed from mental health, things like cognitive behavioral therapy and the like. Many of these mental health techniques are very useful, particularly when it comes to treating co-occurring disorders. But one of the things that initial clinicians discovered when treating substance use disorders was that clients in substance use treatment were very different than clients who were in other types of medical care. Miller and Rolnick talk about this in their own experience, both of whom were trained as mental health clinicians initially. When they started working with people who had substance use disorders, they found that while somebody who has, say, a backache goes to a doctor and says, "Oh, doc, my back hurts, like, please help me," the doctor will do an assessment, try and figure out what's going on. What were you doing when you hurt your back? "Oh, I was lifting boxes." "Okay, this is what I think might help. Why don't we try a combination of heat and ice and some stretching exercises, and then based on how you respond from that, we may want to try chiropractic or maybe yoga or other types of techniques, and I'll give you a painkiller in the meantime for the acute pain." And the person would say, "Great, thanks, doc." Somebody came in to see a nurse because they had diabetes, and the nurse goes over, "Oh, this is what's going on with you. Here's some techniques that we think would help. You should probably really cut back on your sugar, change your diet, talk about insulin." Typically, people are like, "Okay, great, I understand what I need to do." People who come in for mental health counseling, same thing. Somebody suffering from depression, they make an appointment to get mental health treatment. The mental health clinician that they speak with, talks about some techniques, some therapeutic techniques. Maybe the person's prescribed an antidepressant. They say, "Great," and they go away. Whereas people who came into substance use treatment, they found that many times the clients or patients were manifesting what's referred to as resistance. So they come into substance use treatment, they get assessed. "Okay, yeah, you've got a substance use disorder. It's severe. What we really want to do here is start out with total abstinence. Let's get you a sponsor, have you go to some 12-step meetings, want you to attend this outpatient treatment program. We're going to test you to make sure that you stay, sober. We're going to develop a relapse prevention plan." People were like, "Yeah, no, I don't want to do that. No, I think I can, do this by just reducing the amount I drink. Yeah, no, I'm not really interested in doing a relapse prevention plan." So Miller and Rolnick were the first ones that really looked at this saying, what is going on here? We're going to need some kind of a technique specifically to work with people who have substance use disorders. And essentially, it boils down to the concept of ambivalence. So typically, if somebody goes to a doctor because they have a backache, they're not ambivalent about their backache. Ambivalence is wanting two opposing things at the same time, or holding two conflicting beliefs at the same time. So if you go in to get your back treated, you want your back treated. "I'm in pain. I don't want to be in pain anymore. Please help me with my back." If somebody goes in to see a mental health clinician because they're depressed, they don't want to stay depressed. They're seeking relief from their depression. Whereas people who come into substance use treatment, some part of them wants treatment, presumably, otherwise they wouldn't have entered treatment or agreed to enter treatment. But even if somebody was 100% mentally committed to getting substance use treatment, which definitely doesn't always happen, but even if they were 100% mentally committed, biologically, neurobiologically, the body still wants to use the substance. And so what we have is people entering substance use treatment, and a part of them wants to improve their life, get rid of the negative consequences, stop using or reduce the harm from the using they were using before. And some other part of them is like, "Yeah, no, let's carry on. Wait, never? I could never use again? Yeah, no, I don't know if I'm signing up for that." And so while this is happening in the mind, what's happening is as the clinicians or counselors are trying to work with this person, and especially an untrained counselor who's telling them like, "Oh, I got sober, you can do it too, and let me give you lots of advice on how to do it," the person doesn't respond very well to that. They're like, "Yeah, whatever, your life is not my life, and here's all the reasons why your advice isn't going to work." And so what Miller and Rolnick did then was developed a whole series of techniques that they referred to as motivational interviewing. Motivational interviewing, it has two words associated with it. So motivational, meaning that they were attempting to increase motivation for treatment, increase motivation for change. And interviewing, the biggest difference between interviewing is that interviewing is not telling. So an interviewer typically asks questions. They explore with whoever it is that they're interviewing. They try and find out that person's viewpoint on something. And so in motivational interviewing, the techniques utilized are lots of questions, client-centered focus on what's going on with this person to attempt to increase motivation. Solution-focused techniques, which I will also talk about today, really is focusing on the solution rather than all the things that have brought you up to this position. But I'm going to hold off talking about solution-focused techniques until we get there, just so that we can keep the two different techniques clearly in mind. So there are many different specific types of techniques to motivational interviewing that I'm not going to go over in this lecture today. Some of these techniques are covered in much more detail in some of the other clinical courses and in subsequent lectures. So what we're going to do is just talk about some real basic motivational interviewing techniques. So in the alcohol and other drug studies, family dynamics and alcohol and drug counseling class, we actually do this motivation in the class, but we can do it here together as we're going through this lecture. So the first thing that I would invite you to do is to think about a person who elicited resistance from you. Meaning, I want you to think of an actual person, somebody in your life who, when they tried to help you or they gave you advice about something, you pushed back on that. You did not want their help or you did not want their advice. And so this could be a parent, this could be a supervisor, this could be a teacher, you know, a coach or a counselor. And so what I'm going to invite you to do now is write down at least 3 specific personality characteristics or behaviors that this person did that you didn't like. And I will encourage you to pause the lecture while you complete your list. You can pause now. All right, having completed the exercise in which you identified personality characteristics or behaviors from a specific person who elicited resistance from you, now what I'm going to invite you to do is think about a specific person who had a positive influence in your life. Somebody whose help you really benefited from, you enjoyed being with. If you needed help with something, this is the person that you would call and talk to. And now what I want you to do is the same thing. I want you to write a list of at least 3 behaviors or personality characteristics associated with this person. And again, I'm going to invite you to pause the lecture while you write those characteristics down. All right, so comparing the lists, what we do in the class that's taught in the AODS program is we have half the room give us the behaviors or personality characteristics associated with the person they're resistant to. And then we have the other half of the class give the behaviors and personality characteristics of the person who had a positive influence and you were really motivated to go to for help. And typically what you see is a grouping of very similar types of characteristics. So people who elicit resistance tend to be assertive or aggressive know-it-alls who are opinionated and unfeeling and uncaring and demanding and tells you what to do without listening to you, criticizes you for the decisions that you've made, etc. And then the people who generally are positive influences, or those who people are motivated to work with, are open and caring and empathetic and concerned and explore with you and provide lots of positive affirmations, etc. And then usually what I'll do is I'll kind of act out the resistant person based on the actual personality characteristics that the class gave, and then I'll act out the motivational person. And what we see is a pretty consistent picture. While some of the specific personality characteristics might be different, typically they are very similarly grouped. And so the idea here is that if you cannot remember anything about specific characteristics associated with motivational interviewing, each one of you listening to this lecture has inside your own mind 2 models. So the person that you have in your mind who elicited resistance from you, who you did not ever want to go to for help, don't be like that person. Whatever that person did, if you weren't motivated to work with that person, other people aren't going to be motivated to work with you if you act like that person. Whereas in the other part of your mind, you have a model of someone who was a really positive influence where you were motivated to work with. Typically, if you are motivated to work with them because of certain personality characteristics, people are going to be motivated to work with you when you embody those personality characteristics. Again, the idea is that if you are motivated to work with somebody, you are more likely to change. So the essential goal of motivational interviewing is to decrease resistance. We want to take away anything that might cause a client or a patient to be resistant. Recognizing that they're already ambivalent, we don't want to then stack the deck even higher against us by acting in a way that causes them to be more resistant. Instead, what we want to do is act in a way that increases motivation to change, increases motivation to participate in treatment. And in increasing motivation to change, we are helping that person to develop awareness, to consider options of doing things differently, trying new behaviors, and practicing new skill sets. Now, a very important foundational component to motivational interviewing is that motivational interviewing is not giving advice. And this is the very thing that new clinicians have the hardest time learning. The untrained clinician wants to give everybody advice. And it makes sense in some ways because many people who are coming into clinical fields have some kind of personal experience with whatever it is that they're attempting to treat. In addition, clinicians go through schooling. Alcohol and drug counselors go through a lot of schooling. Mental health clinicians go through a lot of schooling. Nurses go through a lot of schooling. And so the tendency is, hey, I've learned all this stuff. I'm going to give you all kinds of advice and I'm going to tell you what to do. So what we do in the family dynamics course is we actually do this persuasion exercise live in the classroom. And so we have everybody pair up. And then what we do is we have the counselor come up with a goal for the client or the partner. It doesn't matter what the goal is. The counselor is the one that gets to choose what the goal is. And then what we do is we have them go and try to convince the other person why he or she should make that change, tell them how important it is to make that change, really kind of go over the top, give them lots of advice, dictate to them what it is that they really need to do. And then what we do is we do the same exact exercise with the same people in the same roles. So the counselor remains a counselor, client remains the client. But this time the counselor has to ask the partner what kind of change he or she would like to make. And then they ask questions like, why do you want to make this change? Have you thought about how you might go about it? What are the 3 best reasons you have to do it? And then what they do is they summarize what they've heard, and then they say to the client, well, what's the first step you could take to make progress towards your goal? And then we have a discussion. Now, it's usually people laugh as they're doing this and generally have a lot of fun with it, and it seems kind of ridiculous. Obviously, a counselor coming up with a goal of what you should do and then trying to give you all kinds of advice and tell you why you should do it, this may not even be your goal. You may have no motivation to do this goal. Even if it is your goal, you probably have a better idea about how to go about this goal than whoever this counselor is that just met you. And so students will report that they were really resistant to the person telling them what it is that they're supposed to do. And it seems obvious, right? Like, yeah, well, of course. Except that there are substance use treatment facilities out there with people who maybe aren't very well trained or are new in the field who think this is the best way to handle a new client. New client comes in and they're like, yeah, you just need to admit to yourself that you're an addict and you need to go to these groups and you need to do all these assignments we're going to ask you to do, and you need to get a sponsor, and you need to go to 90 meetings in 90 days, and you need to stay out of relationships for your first year, and you need to do this, and you need to do this, and you need to do that. And they tell the person everything they're supposed to do. Again, remember, motivational interviewing is not called motivational telling, because typically telling people what to do doesn't motivate them. Motivational interviewing is about interviewing people. So when people instead are asked, what brought you here? What do you hope to get out of this? Even when there's requirements that people have to do, like You may end up working at an agency that's an outpatient treatment program where the clients are required to do, say, 2 sober support meetings, outside of the treatment facility each week. So in a motivational telling or an unmotivational telling, it would be, all right, so you got to do 2 sober support meetings. I'll give you a list. Here's some meetings. 12-step is what we recommend. A couple places down the street. Go to those meetings, try and get a sponsor. Versus, so one of the things that we ask people to do is to go to 2 sober support meetings. How do you feel about that? Do you have any experience with sober support meetings? Oh, great. So it sounds like you've done that before. Do you have a home group that you'd like to attend? Oh, you've never done it before. What do you think you can get out of it? There's multiple kinds of support meetings. There's 12-step meetings. There's things like smart recovery meetings. You ever heard about these things? And so as we're asking questions of the client, what they think about it, what they might be motivated to do, giving them options that they can choose from, typically the person is way more motivated to do whatever it is that's part of their treatment. So the essential idea in motivational interviewing then is that the client is the expert in his or her own life. You are not the expert in the client's life. You have just met this client, or even if you did, an intake and you met with them once before, or even if they're a repeat client, it doesn't matter. Like, you're not the expert in their life. You haven't been living with them their entire life. They know very well what works and what doesn't work. And our job is not to tell them what to do, but instead to try and solicit answers for them about what they want to do and what they think would help in order to get through that. People tend to be way more motivated when they are approached with this kind of motivational interviewing orientation. The idea also is that the client already has the answers in many cases about what will work or not work for him. I remember when I was first doing clinical work and I was treating a new client, and I was at one of those agencies in which clients had to do outside sober support meetings. And, I told the client, hey, this is what you got to do. And, here's a list of, 12-step meetings. And he was like, I'm not doing 12-step meetings. And I was like, okay, well, you have to do sober support, so, these meetings are close. They're, they're nearby. There's a couple of them that are just down the street. I'm not doing that. Okay, well, you got to do that. It's a requirement, for you to be in this program. I'm not doing 12-step meetings. If I have to do 12-step meetings, then I'm leaving this treatment program. And I remember I was like very frustrated with the client. I felt he was being resistant. I was being resistant, obviously. And I was getting irritated about it. And I went to my supervisor and I said, I don't know what to do. He won't do, he won't do 12-step meetings. And my supervisor said, well, what is he willing to do? And I was like, I don't know, because I didn't ask him. And so I went back and said, all right, well, I talked to my supervisor, it is a requirement in our program, but, what would you be willing to do? And the client immediately responded and said, I hate 12-step meetings. I don't believe in that I'm powerless over anything. And I don't like, the focus on a higher power, but I really like SMART meetings. I've done those before. And so I'm willing to do SMART recovery. Now, I was so busy telling the client what it was that he had to do that I never bothered to interview the client about what he thought about this and if he'd had any experiences before and what worked for him and what ideas he had. And so that was totally fine. In our program, he could have done a SMART recovery meeting. And so he did it and he was happy with that and he carried through and was way more motivated. So the idea is you, no matter how well trained you are, have no idea what is going to be best for this client. Now, that's particularly true in treating substance use disorders. Statistically, the last study, the most recent study I read, showed that almost 60%, it was like 57% or 58% of people who become certified alcohol and drug counselors have a substance use disorder themselves or are in recovery. Hopefully their substance use disorder is in remission, meaning that the counselors have had the experience with addiction, right, or developing a substance use disorder. And so for people who have the same experience as somebody else, you're even more prone to giving them advice and telling them what to do. But here's the thing. Even if you have a substance use disorder, even if you had a methamphetamine use disorder, you were addicted to methamphetamine at one point in your life, and you've got a new client and that client has a methamphetamine use disorder, your meth use disorder is not the same thing as that client's meth use disorder. And whatever it is that worked for you in order to get sober may or may not work for this client. who has different values, different experiences, different goals, different expectations, different strengths than you do. And so if you lead with, well, this worked for me, you should just do it, you're going to build resistance. Whereas instead, if you talk with the client about, hey, what works for you? What have you tried before, et cetera, they're going to be more motivated to work with you. Another key point to a person-centered motivational interviewing approach is that it's our job to help the client find ways to solve their own problems. Let's say even in some bizarre, strange world where our advice giving solved all of our clients' problems, that doesn't really help the client, because ultimately they're doing what we tell them to do, but they're not learning how to solve their own problems. And so the idea here is that we are a coach as much as anything. And the analogy of a coach is that let's talk about a sports coach, a coach doesn't actually play the game. The coach helps people practice. The coach will work with somebody, explore, different ways. A soccer coach will, help people learn how to kick the ball better, pass the ball better, right? They'll work collaboratively, but come game time, players play and coaches stand on the sideline. Well, that's the same thing that happens in substance use treatment. We're not going to follow our clients around for the rest of their life. It's not like 5 years from now, they're going to be like, oh my God, what should I do? And we're going to jump out of the bushes or something and tell them like, you should do this. This is what my advice is to you, right? I mean, it's not going to happen. So, that parable too, that's often the biblical parable of, give a person a fish and you feed them for a day, teach a person to fish and you feed them for a lifetime. It's the same principle here. We're going to try and help people figure out how to solve their own problems. We're going to be a coach rather than being an expert telling them what to do. So our job is not to give unsolicited advice and tell the client what to do when we're practicing motivational interviewing. And there's lots and lots and lots of evidence that clients who are told what to do, given lots of advice, generally are resistant, they don't follow through, whereas people that are really approached with a motivational interviewing orientation typically follow through with things, complete things, and feel a lot more motivated. All right. So again, when a client's encouraged, supported to use their already existing strengths and identify resources, they're more motivated to change. So in the spirit of practicing motivational interviewing, building a relationship is everything. It's the first principle, the second principle, the third principle, the 47th principle. So as we are genuinely interested in a person, trying to find out more about them, their story, what's happened to them, how we can best help them, people are typically more motivated to work with us, whereas people resist feedback from somebody who is not genuinely interested in them and their problems. Another thing that motivational interviewing recognizes is that acceptance promotes change. Even people who are highly resistant, meaning, let's take an example of somebody who is only in substance use treatment because their family had an intervention with them and told them, you either go to treatment or we're kicking you out of the house and we're cutting you off and that's it. And so they come into treatment and, you're working with them and you're like, hi, I'm Keith, I'm your new counselor. How do you feel about being here? This is stupid. I don't want to be here. I'm just going to use the minute that I leave here. I'm only doing this so that, my family will let me back home. Or maybe somebody who's gotten a DUI, like I'm only doing this because I need to do it in order to get my license back. And this is dumb and I'm not going to participate and screw you. Right? Okay, that's our client who's like super resistant. You learn about the stages of change in the AODS program. This would be somebody who's in the pre-contemplation stage. Now, if we go to that resistant person and say, well, you have to do it. Don't you understand your family cares about you and you just need to admit that you got a problem. If you didn't have a problem, you wouldn't be here in the first place. If you didn't have a drinking problem, you wouldn't have gotten a DUI. Like, why don't you just get on board and admit you're an addict? We know this works. If you go to you get a sponsor, you work the steps, you're going to get sober. Right? Telling a person who's resistant to all that stuff, it's not like they're going to be like, oh, thank you. I'm so glad you said that to me. Now I'm not resistant anymore. I'm open to whatever it is that you have to say. That's not going to happen, right? Instead, we're just going to build the resistance even higher. Whereas if somebody comes in like that and I say to them like, okay, wow, sounds like you really don't want to be here. And the only reason why you're here is because your family kind of forced you into it. Or, you're only here because it's the only way to get your driver's license back. Yeah, exactly. Yeah, okay, totally. Wow, that sucks. Like, it's got to be really hard to have to go to treatment when you don't really want to go to treatment. Yeah, I don't want to be here. Yeah, totally, man. You don't want to be here. Like, I mean, I get it. It sounds like you don't want to be here. Yeah, exactly. You can almost feel the resistance come down, right? Because I'm not fighting with them. I'm just accepting, like, okay, you don't want to be here. You think this is stupid. You're going to drink the minute that you leave treatment. But in dropping that resistance, there might actually be some openness to doing work together, right? So if I follow that up with like, okay, well, what should we do? I mean, how do you think we should handle this? I mean, if you stay in our program, there's certain things that, you're going to have to do. You're going to have to meet with me once a week. You're going to have to go to 5 groups a week, like, once a day, and work on a relapse prevention plan. So, I mean, I don't know, like, do you think you can do that? Is there some way we can make this so that you can get through it, so that you can get your driver's license back, get back home, whatever? Now I'm being collaborative with the client. I'm trying to build a relationship with this person. I'm accepting the fact that they don't want to be here, and they are typically going to be way more motivated to change, way more willing to work with me. And the last principle is empathy. Empathy is the ability to understand and be sensitive to the feelings of others, even if you don't agree with them, and then communicate that back to the person so that they feel heard and understood. Empathy is covered in all 4 of the clinical classes in all kinds of ways. It's all over all the clinical textbooks that train you how to do clinical and counseling work. Empathy is the single most important thing that's helpful to people as they're moving through treatment. If people feel like somebody is trying to understand them, being sensitive to their needs, sensitive to their resistance, and they're communicating that back to them, then they're generally going to, again, be more motivated to actually do work together. There's a really cute little short video called The Power of Empathy by Brene Brown that's on YouTube. I typically play this in the actual course in the AODS program, but unfortunately Zoom, which is what I'm doing this recording through, blocks any playing of YouTube videos through a link like this. So those of you that want to actually go find this, I encourage you to do so. Just go search The Power of Empathy on YouTube. All right. Person-centered, in continuing with the spirit of motivational interviewing, as I said earlier, it's really about meeting that person where they're at now, being genuine with them. We're trying to figure out what their goals are, trying to help them, not working our agenda, being respectful towards the person, even when they're not being very respectful to us. It really sucks for most of the people we work with. They're coming into treatment, they're going through either acute or post-acute withdrawal. They physically don't feel very good. They mentally don't feel very good. I mean, nobody's like, yay, treatment, I'm so happy to be going and doing this, right? I mean, it's kind of a task that nobody really wants to do. So often people are feeling kind of grumpy and not respectful. But if we are grumpy and disrespectful back, they're not going to want to work with us. Whereas if we're being respectful and genuine, trying to help to understand them, then we will tend to motivate them. And again, in the idea in motivational interviewing is that our job is to be a collaborative coach with the client. We're there to help them with their problems, not try and solve their problems for them. All right. So there's much more to motivational interviewing than just that. But if you can get some of those foundational principles down, be that person that most motivated you, people are going to be more motivated. Don't give people advice. Don't tell them what to do. Don't push your agenda on them. Instead, work with them, trying to understand what they're willing to do, what's worked for them before, how they want to handle this. Be respectful, be genuine. People are typically more motivated, and you're actually going to get something accomplished together. So the second evidence-based technique that is also a recommended best practice when working with substance use disorders is solution-focused techniques. So solution-focused techniques are oriented towards helping people find solutions and solve problems, again, without giving advice, because the same principle we talked about with MI, people are way more motivated when the goal and the plan comes from within. And so we're going to help them figure out what their solutions are. Now, most people know what solutions are, even if they're reluctant to use them. The solutions are there. So in being a collaborative coach, we want to explore with that person, hey, what do you think would be really helpful here? Research has shown over and over again, when somebody comes to really any kind of treatment, but certainly a substance use treatment facility, looking for help, and you say to them like, well, what do you think might be helpful here? Even if they say, I don't know, that's actually not true. If you ask them a couple of questions, you'll usually find out they do know. Certainly they know what wouldn't work if they've tried it before, but they often have some ideas about what might work. And so part of a solution-focused technique is to ask them the question, well, what have you tried in the past that worked? And then to ask them, well, what have you tried that didn't work before? That is already a built-in solution-focused process, because if they've tried something in the past that worked, well, then do more of that. If you ask somebody, like, if somebody comes in and you're like, hey, so I see that you've been in treatment twice before, finished one of them, that's great. And at one point you were able to put together almost 3 months of sobriety. So what worked for you those 3 months? How did you stay sober? Well, when I finished the program, like they had this like aftercare program and they made us get a sponsor, and I was working with a sponsor and I was going to meetings at least for, like a couple months. And but then my sponsor like moved away, and then I stopped going to meetings, and then I relapsed. Well, okay, well, great. Sounds like one of the things that was really helpful was when you got out of treatment before, you had a sponsor, you were going to meetings, you were participating in an aftercare program, and that helped to keep you sober for a period of time. So we should talk about that, so that as we get closer to discharging from this treatment program, maybe we should put that in place. If it worked before, it's probably going to work again. How do you feel about that? Yeah, I guess I could work with that. The other thing is we want to ask what didn't work, right? Same scenario, like we could ask like, okay, well, so, last time that you finished treatment, you were able to stay sober for a period of time. What didn't work for you? Oh man, like, I don't know, like I was really into this, like, I met this person, I was really into them, and they were smoking pot, and I was kind of like, well, that's not really my drug of choice, so it doesn't really matter. But I don't know, like we started hanging out, and then one night we were at a party, and somebody was using heroin, and that is my drug of choice. And like, and I don't know, like I was just there, and I don't know, I relapsed. Okay. So it sounds like one of the things that didn't work before was by maybe getting a relationship too fast with somebody who was still using, that even if it wasn't your drug of choice, it kind of led to you going back to your drug of choice. Yeah. Okay. Well, we should probably think about that as we, move through treatment, and especially as we're talking about discharge, we should maybe consider like, what's the plan in terms of relationships, getting involved with people who use. Do you think we should look at that and maybe not do the same exact thing again? Yeah, because that didn't work. Right, so what we're doing in this collaborative way of talking about, well, what worked and what didn't work, is we're coming up with a game plan. If it worked before, do more of that. If it didn't work before, well, then don't do that, right? If it didn't work before, there might be a little teeny tiny possibility that it might work this time, but it's far more likely if it didn't work before, it's probably not going to work again. And then again, part of the solution-focused technique is asking the person, like, well, what do you think the first step would be if you wanted to make this change? Again, it's collaborative, it's working with the person, it's coaching them to come up with their own solutions. So there's lots of questions we can use to promote change. And again, you get an enormous amount of training in solution-focused counseling throughout the AODS program, particularly in the clinical classes. But questions like, well, why do you want to make this change? Why did you enter treatment at this point in your life? What are some ideas you have about how to do this? Who are some resources you have? Who might be helpful for you in this process? Well, if an expert was going to be giving you advice, what do you think they'd tell you? Well, what do you think about trying that? Again, we're interviewing, not telling. We're trying to find solutions rather than focusing on the problem that brought the person to treatment. This is a classic question associated with solution-focused counseling called the miracle question. When somebody is feeling paralyzed, they have no idea what to do. They're like, I don't know how to solve my problems. I don't know what I should even do. Everything's just totally screwed up. Okay. Well, let's do this for a second. I want you to just kind of like, I want you to imagine with me for a minute. So if you woke up tomorrow, if you go to sleep tonight and you woke up tomorrow and a miracle had happened and that you no longer had this problem, what would be different in your life? If the client's like, well, I mean, what would be different, I guess, is that, I wouldn't be addicted to drugs anymore. Yeah, and what else would be different? I mean, I don't know. I guess I'd have a job and I'd have money and maybe I'd have a relationship and like, okay, like, well, what else would be different? Well, I wouldn't be like, living in like a sober living facility. I mean, I guess I'd have my own place and like, okay. And so what we do is we're setting essentially target goals for the client. And once they identify like what would be different, Well, now we can go back to the same solution-focused approach. Like, okay, well, I mean, what about getting a job? What have you done for work in the past? What have you liked doing for work in the past? How did you get your first job that you really liked? What were the things that you did before that worked? Okay, well, like, I mean, what wasn't working, right? How did you lose those jobs? Well, let's not do that anymore. And so what we do is we're helping the client come up with their own solutions towards their own goals to break that logjam and that feeling of, I don't know what to do and I'm paralyzed. All right, so that's actually a lot, even though I've only given you the briefest interviews to motivational interviewing and solution-focused counseling. Your brain might be like, oh my God, it's too much. How am I going to remember all this when I'm sitting with a client? And so there's two really great acronyms to remember. Acronyms, the first letter of the word is made up by the phrase of the thing you're trying to remember. And so there's a great one that's referred to as WAIT. So remember, in the spirit of motivational interviewing and solution-focused counseling, it's not my show. It's not the Keith show. It's not about me talking to my client and telling them what to do and explaining to them why this is going to work and all this stuff. The goal is for me to be asking questions, listening to my client, being collaborative. So WAIT stands for, why am I talking? When I was in clinical training, I had a supervisor teach me this, and it was amazing how many times it would pop into my head. I'd be talking to a client and I'd hear my own voice, kind of like the way I'm hearing my voice right now as I'm lecturing to a computer screen. And as soon as I heard my voice, it was like, wait, why am I talking? And the essential idea here is that if I'm talking, then I'm probably not listening. And so that's an important question. Why am I talking right now? Should I be listening to my client instead? You know, or am I waiting for, you know, a chance to speak or wait for a chance to speak rather than be talking right now? How can I be more client-centered? Am I about to give advice? Am I making suggestions? Am I trying to be an expert in my client's life? Is what I'm about to say really necessary for this situation? Or am I just piling words on top of words instead of asking my client what he or she thinks about this? And ultimately, is there a way to ask a question to help empower my client rather than me talking to them? And so a great way to simply remember this is anytime you hear your own voice when you're doing clinical work, think, wait, why am I talking? Sometimes it might be appropriate to be talking, but many times when we're talking, it might actually be better to be listening in that moment or empowering our clients by asking questions rather than us filling the space with words. The other acronym that actually comes out of motivational interviewing is referred to as the oars. I like to think of the oars as what you do when you're in a boat and you're stuck. If you've ever done like river rafting or something like that, sometimes you get caught, you know, where you're stuck on a rock, or you get caught one of these eddies and you're not moving very fast or very far. And the idea here is that when you're stuck in a boat, you use the oars to like push yourself off the rock or push yourself out of that eddy and to get moving again. So the acronym of the oars stands for open-ended questions. So asking open-ended questions, an open-ended question cannot be answered with yes or no. But again, in the spirit of interviewing our clients, we're going to ask them, well, what do you think about that? Why do you think that might have worked for you? How do you think you might be able to best solve this problem? Affirmations. So A is affirmations, to affirm somebody's strength or goals. And to affirm somebody is to offer them encouragement or emotional support. Hey, like, I totally appreciate you really don't want to be here. And it sounds like you're really forced into this situation, but you know, you're willing to work with me in the program as long as you're here to do what you need to in order to get your driver's license back. So great. I really appreciate the fact that you're coming in with a good attitude. R is reflect back what you heard the person saying to clarify and assure that you heard him. So when you're stuck and you're like, oh my God, I don't know what I should do right now, you can say like, okay, yeah. So I think what I'm hearing you say is that you were able to stay sober for a period of time before by utilizing sponsorship and sober support meetings, and that, you know, that kind of didn't work for you when you stopped doing that. Am I understanding that right? Yeah, exactly. Okay, great. Well, let's build from there. And then the S stands for summarizing. So summarizing is summarize everything that you've heard up to this point, and now we're going to move into the solution of identifying the first steps. So WAIT and oars are two acronyms that you can use when you're either talking too much or you're feeling stuck and you don't know what to do next. All right, so that takes us then to the end of this very basic introduction of motivational interviewing and solution-focused counseling approaches. Again, with the idea that we are partners in our clients' progress. So with that, again, in the AODS program, students who attend the AODS clinical training courses will get lots and lots and lots of practice in the classroom. We will have tons and tons of scenarios. In the family dynamics class, we create family scenarios. We have the students play family members. We have the counselors introduced to like, okay, here's the scenario, what are you gonna do? The counselors get all kinds of opportunities to practice their motivational interviewing and solution-focused counseling techniques. It is a best practice recommendation for any kind of clinical training that you get into a program or you get to actively practice. Passively listening to lectures like this and reading books is great, but until you actively get a chance to practice, you usually aren't adequately prepared. So the AODS program at San Diego City College is an excellent program where you not only learn the clinical techniques necessary to work in drug treatment, but you get the chance to practice them as well. I hope you found this helpful. Until the next lecture.